to do its job.
Precisely. And as we were saying, it takes time for the brain to adjust to this increased serotonin signaling.
Like what kind of changes?
Think of it like this. The brain has to adjust to this new level of signaling. It might involve changes in the sensitivity of serotonin receptors or the growth of new connections between neurons.
So it's not just flipping a switch, it's more like the brain has to rewire itself a little bit in response to the increased serotonin.
Exactly. And these downstream effects, this adaptation, takes time. That's why you don't feel the full benefit for several weeks.
So what does this all mean? It means patience is key, and it's so important to explain this to someone starting an SSRI so they don't get discouraged early on.
Absolutely. Managing expectations is crucial. And understanding this delay can also help us when we talk about other psychiatric medications and how they work over time.
Important things to discuss up front then. Now, serotonin syndrome, that sounds pretty serious.
It is serious. It's basically too much serotonin activity. It often happens if SSRIs are mixed with other things that boost serotonin, like MAOIs, older antidepressants,
Okay.
or triptans for migraines, even St. John's wort, the herbal supplement.
Oh, yeah, uh-huh.
Can you explain, MIOIs, that whatever you said, as well as the other things that can cause serotonin syndrome? Yeah.
That's a really important question. When we talk about the symptoms of serotonin syndrome,
We're describing a real, potentially dangerous condition that needs immediate medical attention.
so yes, these are serious physical symptoms that indicate a problem in the body.
It's not just a feeling or a thought, it's a physiological response to having too much serotonin activity in the nervous system.
And you're right to ask about what else can cause it besides mixing SSRIs.
As we were saying, combining SSRIs with MAOIs, which are an older class of antidepressants, can definitely lead to it.
And you mentioned triptans. Those are often used for migraine headaches.
Exactly. Some pain medications and even certain illicit drugs can also increase serotonin levels and raise the risk.
Even some herbal supplements like St. John's wort can play a role in increasing serotonin.
So it's really about the total amount of serotonin activity in the system.
Right. And the symptoms you might see.
Early signs include things like agitation, maybe someone seems restless or anxious.
And diaphoresis, which is excessive sweating.
Yes, that's another common early indicator. Also myoclonus, which are those muscle twitches or jerks.
And hyperreflexia, really exaggerated reflexes.
That's right, and as it progresses, you might see an elevated temperature.
And problems with heart rate, tachycardia, a really fast heartbeat.
Even a hypertensive crisis, dangerously high blood pressure, so it's a cascade of physical symptoms.
Okay, a lot to watch for. If you see those signs, what's the immediate response?
First thing, stop the SSRI. Stop any other serotonergic drug they're on immediately. Get IV fluids going and notify the provider, STAT.
Right.
In bad cases, they might need benzodiazepines for agitation, maybe even cyproheptadine to block serotonin. So you see, targeting serotonin helps with depression. But then you look at something like bipolar disorder.
Oh, okay. Shifting gears.
Yeah, and that's a different ballgame, much more complex, involves bigger swings, different neurochemicals, so the treatments are different too.
Because bipolar isn't just depression, it's those swings, right? Between highs and lows.
Exactly, you have these alternating episodes. Mania, or the milder hypomania, and then depression.
Okay.
Mania or hypomania means elevated mood, tons of energy, needing less sleep, grandiosity, sometimes impulsivity, maybe even psychosis. And the depressive episodes look a lot like regular depression. Oh yeah,
So, few things. What is the etymology of mania? And then, is there an element? So, but by what you're saying, what I have understood is that there's an element of depression within a bipolar disorder, right? And then you said impulsiveness. What does that mean? Can you give me real life examples?
Those are all really insightful questions. Let's take them one by one.
absolutely. Starting with the etymology of mania, it comes from the Greek word for madness or frenzy.
Which, when you think about the symptoms we described, that sense of heightened energy and sometimes disorganized thought, it kind of fits.
It does, and you're spot on about bipolar disorder, including episodes of depression. That's a core characteristic.
It's not just about the highs of mania or hypomania. The lows of depression are equally significant and part of the diagnosis.
Exactly. Someone with bipolar disorder experiences both ends of the mood spectrum, often cycling between them.
And you asked about impulsivity. That refers to acting without really thinking through the consequences.
Right, making quick decisions or taking actions that might have negative outcomes without considering them fully.
For a real life example, someone in a manic phase might impulsively spend a huge amount of money they don't have.
Or they might engage in risky behaviors they wouldn't normally, like making rash business decisions or engaging in unsafe activities.
It's a lack of that normal filter or consideration of the potential downside.
Precisely. So, as we were saying, mania or hypomania involves that elevated mood, high energy, decreased need for sleep, sometimes a sense of being overly important or capable, which is grandiosity.
It's complex.
Very. We think the mood swings in bipolar disorder involve a dysregulation of several neurotransmitters and their interactions.
Now, we often hear about lithium as a key mood stabilizer.
Yes, lithium is considered a gold standard for treating bipolar disorder.
Hey, yeah, what's up?
You mentioned something about like dysregulation of several neurotransmitters in bipolar disorder. I mean, can you explain that and tell me what these neurotransmitters are briefly, and then explain what's happening, what's going on?
Absolutely, that's a really important point. When we talk about neurotransmitters, think of them as chemical messengers in the brain, allowing nerve cells to communicate with each other.
Okay, so like little signals being passed around.
Exactly. In bipolar disorder, it's believed there's an imbalance or instability in several of these key neurotransmitters that help regulate mood and energy.
And which ones are we talking about primarily?
Serotonin is one, as we discussed with depression. It plays a big role in mood regulation. Then there's dopamine, involved in pleasure, motivation, and also energy levels.
Right, dopamine is often linked to feeling good.
Precisely. And norepinephrine, which is similar to adrenaline, affects alertness, attention, and also mood.
So what's the dysregulation part? What's going wrong with these messengers in bipolar disorder?
It's not fully understood, but it seems like the levels and activity of these neurotransmitters can fluctuate more dramatically in people with bipolar disorder.
So sometimes they might be too high, leading to that energized manic state.
That's the idea. An overactivity of dopamine and norepinephrine might contribute to the racing thoughts, increased energy, and impulsivity we see in mania.
And then the depressive episodes, that would be more of a drop in the levels or activity of these neurotransmitters.
That's the general understanding, similar to what we see in unipolar depression with lower levels of serotonin, dopamine, and norepinephrine, contributing to the low mood and lack of energy.
So it's the seesaw effect with these brain chemicals, going from too much activity to not enough.
That's a good way to put it. And it's this instability that mood stabilizers like lithium aim to address, although the exact mechanisms are still being researched.
Wow.
So you have to monitor blood levels really closely, regularly. Signs of toxicity, they can start with nausea, vomiting.
Okay, PI stuff.
Yeah, then move to neurological things like coarse tremors, unsteadiness, ataxia, confusion. Severe cases can even lead to seizures.
And side effects even in the therapeutic range.
Oh, yeah. Oh, go for it.
What is the therapeutic index for lithium? And you said something about PI. What does that acronym mean?
That's a really clear and important question. The therapeutic index for something like lithium, it's basically a measure of how safe the drug is.
Think of it like this. It's the range between the dose that's effective and the dose that's actually harmful or toxic.
So a narrow therapeutic index, like with lithium being 0.6 to 1.2 MEQL, means that sweet spot of effectiveness is very close to the level where it can become dangerous.
Exactly. That's why we emphasize such careful monitoring of lithium blood levels. A small increase in dose or a change in how the body processes it can push someone into the toxic range pretty quickly.
You all asked about pi. I think you might have heard IP as in IP3.
Yes, IP3 stands for inositol triphosphate. It's one of those second messenger systems in neurons that lithium likely affects.
Okay, let's unpack this. So when a neurotransmitter like serotonin binds to a receptor on a brain cell, it often triggers a series of events inside the cell.
Right. These intracellular signals are the second messengers. They help carry the message from the receptor to other parts of the cell.
Here's where it gets really interesting. Lithium seems to interfere with these IP3 signaling pathways.
What's fascinating here is that by modulating these second messengers, lithium is thought to help stabilize mood, though the precise way it does this is still an area of active research.
So what does this all mean? It's not directly boosting a neurotransmitter. Oh yeah, let's hear it.
Wait. Can you re-explain that in a very simple way? When you said something about IP3, second messenger, blah, 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 and then you brought up serotonin, all of that was confusing. What are you trying to say? Can you break it down one step at a time? You're saying that serotonin kind of like disrupts something and that actually improves the mood. Can you explain that in detail in a very simple way, please?
Okay, let's take a step back and simplify that.
You're right, it can sound a bit complicated.
So think of serotonin as one type of message being sent between brain cells.
And to send that message, it binds to a specific spot, an acceptor, on the receiving brain cell.
Now, when lithium comes along, it doesn't directly mess with the serotonin itself at that receptor.
Instead, it seems to affect what happens inside that receiving brain cell after the serotonin message is received.
That's where the second messenger idea comes in. It's like a chain reaction that gets started inside the cell.
And IP3 is just one of those links in the chain. Lithium seems to make that chain reaction a little less intense or maybe more stable.
So it's not that serotonin is being disrupted in a bad way.
No, it's more like lithium is helping the brain cells respond to serotonin in a more balanced way over time.
Think of it like turning down the volume a little bit on a signal that might be too strong or erratic in bipolar disorder.
Exactly. By influencing those internal signals, lithium helps to smooth out those big mood swings.
So it's not directly about serotonin levels themselves in this case, but more about how the brain cells react to those signals. Does that make a bit more sense? Yep. Go on.
All right, let me say it in my own words. All right, let's say serotonin is being sent from point A to point B, right? Through that synaptic cleft or whatever you call it. So now serotonin goes from like neuron A to neuron B, and then on neuron B there are certain receptors, okay? Now, serotonin binds to these receptors and kind of like enters the cell. Normally, it follows a specific pathway once it's inside the cell. However, in particular in the case of people with kind of like bipolar disorder, it might once it binds to the receptor on the neuron B, it starts traveling within the cell super fast. Now, when lithium comes to the equation, what it does is that maybe kind of like it slows down that a little bit.
Okay, I see what you're getting at. You got the basics of the serotonin transmission down.
Yeah, that point A to point B analogy across the synapse works well.
Now, you're imagining that once serotonin binds to the receptor on neuron B, the signal inside that neuron goes into overdrive in bipolar disorder.
That's a really interesting way to think about it. Like the message is being amplified too much.
And you're wondering if lithium acts like a brake on that internal superfast signaling.
Exactly. Does it kind of slow things down inside neuron B?
In a simplified sense, yes, that's not a bad way to visualize it.
Okay, lithium isn't stopping serotonin from binding.
Right, it's more about what happens after that binding occurs.
Here's where it gets really interesting. Lithium seems to make those internal pathways less excitable or less prone to those rapid extreme swings.
What's fascinating here is that by influencing those second messengers like we were talking about, it helps to create more stability within the cell.
So what does this all mean? It's like lithium is helping neuron B process the serotonin message in a more balanced way, preventing it from going into that super fast mode.
Oh yeah, go on.
All right, cool. So when you say second messenger is basically whatever carries serotonin once it binds to that neuron that let's call B. Basically, serotonin goes from A to B, it binds to B, then it's supposed to follow a certain pathway, and to follow that pathway, there's a second messenger that helps it do that, okay? And, when it does that sometimes, or in people with bipolar disorder, it might be too excited or it goes, too high. So lithium comes over and kind of like regulates that, right?
That's a really great way to put it. You've got the core idea down.
Yeah, you've really simplified it nicely. It's that internal signaling that lithium helps to keep in check.
Precisely. It's like a dampening effect on those internal signals, which ultimately helps to stabilize mood over time.
That's a really clear way to put it. Thanks for putting it in your own word. That really solidifies it. Now we should move on to some other important medications used in psychiatry.
Absolutely. Let's talk about quetiapine, often known as Seroquel. It's classified as an atypical antipsychotic.
But it's also frequently used to help stabilize mood in bipolar disorder.
Oh, back to our listener. What's up?
Why is it called atypical? Can you tell me the story behind it? And why do we call others typical? Like, where does the distinction stem from?
That's a fantastic question. The typical versus atypical distinction for antipsychotics is really about when they were developed and how they primarily work.
Exactly. The typical or first-generation antipsychotics came first in the mid-20th century. Think of medications like haloperidol.
And these early medications primarily targeted one specific neurotransmitter, dopamine. They were very effective at reducing those positive symptoms of schizophrenia, like hallucinations.
But because they so strongly block dopamine, they came with a higher risk of those extrapyramidal side effects, or EPS, that we mentioned earlier.
Things like muscle stiffness and tremors. So what about the atypical ones, like Seroquel, which came later?
The atypical or second-generation antipsychotics were developed with a slightly different approach. While they still affect dopamine, they also have a significant impact on other neurotransmitters, particularly serotonin.
Here's where it gets really interesting. This broader action is thought to be why they generally have a lower risk of those EPS side effects compared to the typicals.
What's fascinating here is that this difference in how they act on neurotransmitters is the key to the... Oh yeah, let's hear it.
All right, all right, all right. Let's take this slowly. When you say EPS, what does the acronym stand for? And explain the definition of it and what's happening and why it's happening, what's involved, what's going on.
Absolutely. Let's break down EPS for you. It stands for extrapyramidal symptoms.
Okay, let's unpack this. Extrapyramidal refers to a set of nerve pathways in the brain that control motor movements, posture, and coordination.
Here's where it gets really interesting. These pathways are influenced by dopamine.
So when those first generation or typical antipsychotics strongly block dopamine, it can throw these motor control systems off balance.
What's involved are a few different types of involuntary movements and muscle issues.
You might see acute dystonia, which involves sudden and sustained muscle contractions, often in the neck, eyes, or tongue.
Parkinsonism is another one where someone might develop symptoms similar to Parkinson's disease, like tremors, rigidity, and slowed movement.
Then there's akathisia, that really uncomfortable feeling of inner restlessness where someone feels like they constantly need to move.
And finally, tardive dyskinesia, which can develop over time and involves repetitive involuntary movements, often of the face, lips, and tongue.
So what does this all mean? It's all tied to that strong dopamine blockade by the older antipsychotic medications.
Exactly. The atypical antipsychotics, because they also affect other neurotransmitters like serotonin, tend to have a lower risk of causing these EPS side effects.
That's a really helpful breakdown. Now, we were just about to talk about another important side effect of Seroquel.
Yes, one of the most critical nursing concerns with Seroquel is QTC prolongation.
You're referring to QTC prolongation that can show up on an EKG.
That's right. If that QTC interval becomes too extended, it can unfortunately raise the risk of serious heart rhythm problems.
So this is definitely something we need to be vigilant about. Who is most at risk for this?
Individuals who already have electrolyte imbalances, such as low potassium or magnesium, or those with pre-existing heart conditions.
This really highlights the importance of monitoring their vital signs regularly.
Absolutely. And it's important to ask patients if they are experiencing any dizziness or palpitations.
That's a good reminder. Another mood stabilizer we often encounter is valproic acid, or Depakote.
Yes, that medication was initially developed to treat seizures.
But it was also found to be effective in stabilizing mood. How does Depakote achieve this?
It's believed to work by increasing the levels of GABA, which is a neurotransmitter that helps to calm brain activity.
So it helps to regulate the firing of nerve cells. That makes sense.
And the primary thing we monitor with Depakote relates to the liver.
It's broken down by the liver, isn't it?
Exactly. So regular checks of their liver function tests, or LFTs, are essential.
Paying close attention to the ALT and AST levels.
And if those liver enzyme levels come back higher than they should be,
Significantly elevated.
in that situation, the dose should be held, and the doctor needs to be contacted immediately for further instructions.
That's a really critical point for nurses to remember.
Yeah.
All right, two things like Seroquel, quetiapine, I don't know how you pronounce it. So, you know how you said that lithium works by, we've explained it earlier, by kind of like regulating those levels of serotonin that go into the other end or the next neuron, okay, and then kind of like affect that second messenger. How does Seroquel work? What does it affect? And then you said Depakote affects GABA, right? Can you explain that a little bit further for Seroquel and Depakote?
Those are excellent questions. Let's tackle Seroquel first.
You're right. We spent some time talking about how lithium and Depakote work.
So Seroquel, or quetiapine, is a bit different. It's an atypical antipsychotic.
And as we touched on, atypicals have a broader effect on neurotransmitters.
Unlike lithium, which seems to mainly affect those internal signaling pathways,
Seroquel affects both dopamine and serotonin receptors in the brain.
it acts as an antagonist, meaning it blocks these receptors to some degree.
So while lithium helps to stabilize things internally, Seroquel is more directly influencing the neurotransmitter signals themselves.
Now, regarding Depakoda and GABA,
You're right, we mentioned it increases GABA levels.
GABA is a really important inhibitory neurotransmitter.
Think of it as the brain's natural way of calming down nerve activity.
So by increasing GABA, Depakoda helps to reduce excessive neuronal firing.
This could be particularly helpful in managing the rapid shifts in mood seen in bipolar disorder.
And you also asked about typical antipsychotics.
As we discussed the first-generation antipsychotics, the typicals primarily target dopamine,
That strong dopamine blockade is effective for certain symptoms.
but it's also what leads to that higher risk of EPS, those movement-related side effects.
Okay, let's move on to another major psychiatric disorder, schizophrenia.
Right, this is a complex...
Oh, yeah. Huh?
All right, wait. I'm a little bit confused. All right. We said that, lithium, was a, what do you call it? Like a mood regulator, right? And it is used for like bipolar disorders, right? And then you said for bipolar disorders, we also use Seroquel and we use Depakote. But when you talked about Seroquel, you said that it is a, I don't remember, first or second generation antipsychotic. Are antipsychotics the same as mood regulators? I'm confused. I thought it was two distinct things, two different things. Are they the same? Does that mean, by the same rule, that lithium is also an antipsychotic?
That's a really understandable kind of confusion. It can definitely seem like we're using different labels for similar things.
You're right to notice that we've discussed lithium as a mood stabilizer for bipolar disorder.
And then we brought up Seroquel, classifying it as an antipsychotic, but also mentioning its use in bipolar disorder.
So are antipsychotics and mood stabilizers the same thing? Generally, no, they're not.
Think of it this way. Mood stabilizers, like lithium, primarily work to even out those highs and lows characteristic of bipolar disorder.
Their main goal is to prevent both manic and depressive episodes and to keep mood within a more stable range.
Now, antipsychotics, whether the older typicals or the newer atypicals like Seroquel, are primarily used to treat psychotic disorders like schizophrenia.
These medications target symptoms like hallucinations and delusions, which are often linked to an excess of dopamine activity on the brain.
However, what's interesting is that some atypical antipsychotics, like Seroquel, also have mood-stabilizing properties.
The exact reason for this is still being researched, but it's thought to be related to their effects on multiple neurotransmitters, including serotonin as well as dopamine.
So Seroquel can act as both by affecting dopamine and serotonin in certain ways, and as a mood stabilizer, likely through some of those same mechanisms.
But that doesn't mean all mood stabilizers are antipsychotics or vice versa.
For example, lithium is a very effective mood stabilizer, but it's not typically classified as an antipsychotic because its main action isn't directly on those dopamine pathways in the same way.
And while typical antipsychotics are effective against psychosis, they aren't always the first-line treatment for mood stabilization in bipolar disorder due to their side effect profile.
So they are different categories of medications, but some medications, particularly certain atypicals, can have effects that overlap and make them useful for treating more than one type of condition. Does that help clarify things a bit?
Okay, let's move on to another major psychiatric disorder, schizophrenia.
Right. And sometimes those auditory hallucinations can be quite... Oh, go for it.
Wait, just like you did with Seroquel in relation to lithium, and you compared it, and you said that, it can be used for bipolar disorders, even though it's not a mood regulator. It works more by, by regulating that dopamine, etc. Even though it's considered a second generation antipsychotic, also known as atypical antipsychotic. So can you do the same thing for Depakote, kind of like explain it? The same way you compared those two and, Depakote, valproic acid.
That's a great request. It's helpful to draw those comparisons.
You want to understand Depakote or valproic acid. in a similar way.
So we know lithium is a primary mood stabilizer.
And it works in those complex ways, affecting intracellular signals.
Now, Depakote, like lithium, is also a mood stabilizer.
And it's frequently used in bipolar disorder to manage mood swings.
But its primary classification isn't antipsychotic,
That's right. Its main mechanism, as we discussed, involves boosting GABA.
which helps to calm down that excessive brain activity.
So while it stabilizes mood, it's working through a different neurotransmitter system than antipsychotics typically target.
Antipsychotics, remember, mainly affect dopamine and sometimes serotonin.
Depakote's focus on GABA is what sets it apart in its primary action.
However, like some atypicals, Depakote might have broader effects.
But its core action and initial development were as an anticonvulsant.
So while all three can be used in bipolar disorder,
Lithium, Seroquel, and Depakote have distinct primary ways of working.
does that kind of paint a clear picture of Depakote's role?
Okay, let's get back to schizophrenia now.
Oh, yeah, uh-huh.
Wait. Now, let's say we have a patient who presents in a certain way, okay? And, let's say we just see their behavior, etc. How do we know which medication will work for them? Because, we just went over three of them briefly, that are used for bipolar disorders. Lithium, Seroquel, also known as quetiapine, and then Depakote, right? Each one of them targets different neurotransmitters and work through different neural pathways. Now, how do we know? Like, imagine that I'm a doctor, right? How do I know whether to give this patient lithium or Seroquel or Depakote? What do I base it on,
That's a really critical question, and it gets to the heart of the art and science of psychiatry.
Yeah, it's not like there's a one-size-fits-all answer, unfortunately.
Absolutely. When a patient presents with symptoms of bipolar disorder, the initial assessment is really comprehensive.
It's not just about observing behavior on a single day.
We're looking at their full history, including the pattern of their mood episodes.
Have they had more manic episodes or depressive episodes? What's the cycling like?
Family history is also a big factor. Is there a history of bipolar disorder or other mental health conditions?
And any previous responses to medications are really valuable information. What has worked or not worked in the past?
Exactly. Side effect profiles of the medications are also carefully considered.
For someone with weight concerns, a medication with a lower risk of weight gain might be preferred.
Or if sleep is a major issue, that might influence the choice.
You mentioned Seroquel can have an impact on sleep, for example.
It can, yes. And lithium, while very effective, requires regular blood monitoring, which needs to be factored in.
So it's a really individualized decision based on a lot of different pieces of information.
And sometimes it involves a bit of trial and error to find the best fit for that particular patient.
It's a collaborative process between the doctor and the patient, discussing potential benefits and risks.
Absolutely. Now let's get back to schizophrenia and those auditory hallucinations. Oh, yeah. Uh-huh.
Wait. So you said family history is taken into consideration before choosing a medication. I'm just, trying to figure this out. And then you said it's kind of like trial and error and depends on, for example, if we know that a patient has heart issues, right, we wouldn't necessarily start with Seroquel because it can increase that QT interval. With the same token, if someone, for example, has liver issues and we get their blood tested and we have that they have elevated liver enzymes, then we might not give them valproic acid, right? And so on and so on. Can you create a scenario, please?
That's a really insightful way to synthesize what we've been discussing. You've definitely grasped the key considerations.
Yeah, you're absolutely right in your examples about heart and liver issues guiding medication choices. Let's create a scenario to illustrate this.
Imagine a 25-year-old who presents with the first episode of what appears to be mania. They're experiencing racing thoughts, decreased need for sleep, and inflated self-esteem.
So, based on those initial symptoms, bipolar disorder is definitely on the differential diagnosis list.
Now let's say this young person's medical history reveals they have a pre-existing heart condition, specifically a prolonged QT interval on a previous EKG.
Given what we know about Seroquel and its potential to further prolong the QT interval, that might make us more cautious about using it as a first-line treatment.
Exactly. The risk of a serious cardiac event will be a significant concern.
In this scenario, the clinician might lean towards lithium as a first-line mood stabilizer, provided there are no contraindications like kidney issues.
And they would, of course, get baseline kidney function tests before starting lithium.
Now let's add another layer. Suppose this patient also has a family history of bipolar disorder, where lithium has been very effective with minimal side effects for a close relative.
That positive family response to lithium would further strengthen the case for considering it as a primary option.
On the other hand, if this same patient's initial blood work showed elevated liver enzymes, that would make us very hesitant to start Depakote due to its potential impact on liver function.
In that case, the clinician would need to carefully weigh the risks and benefits of all available options, perhaps consulting with specialists.
It really highlights how all these different factors, the patient's current health, their medical history, family history, and potential medication side effects, all come into play when making treatment decisions.
It's a complex puzzle that requires careful consideration of all the pieces. Now, getting back to schizophrenia.
Right. And sometimes those auditory hallucinations can be quite subtle for us to, hey, yeah, what's up?
Wait, not so fast. So basically, I have a few questions. So you're saying, according to you, that lithium is metabolized or processed in the kidneys, right? That also, what is it called? Give me a second. Depakote is metabolized in the liver. That's why why those LFTs are important. And how about Seroquel? Where is that metabolized? Okay. Another question that I want to get answered, to be answered, is what does a differential diagnosis mean? Explain it, like in a very detailed way.
Those are excellent clarifying questions. Let's break them down.
You're right about lithium being primarily processed by the kidneys. That's why we monitor renal function so closely.
And you're also correct that Depakote, or valproic acid, is metabolized by the liver, hence the importance of checking those LFTs.
Now, Seroquel, or quetiapine, is mainly metabolized by the liver as well through various enzyme pathways.
So just like with Depakote, liver function can be a consideration when prescribing Seroquel, although the specific enzymes involved are different.
And your other question about differential diagnosis is crucial.
Okay, let's unpack this. A differential diagnosis is essentially a list of possible conditions that could be causing a patient's symptoms.
Here's where it gets really interesting. When a patient presents with a set of signs and symptoms, it's rarely clear-cut what the exact diagnosis is right away.
Think of it like a detective trying to solve a case. They have clues the patient's reported symptoms, their behavior, medical history, and findings from examinations.
What's fascinating here is that several different conditions might share some of the same clues. The differential diagnosis is the detective list of all the potential suspects.
So, for example, if someone is experiencing low mood and fatigue, that could be major depressive disorder.
But it could also be a symptom of hypothyroidism, or even a side effect of certain medications. These would all be part of the initial differential diagnosis.
What does this all mean for us as healthcare professionals? It means we need to systematically consider all the possibilities.
We gather more information through detailed history taking, physical exams, lab tests, and sometimes consultations with other specialists.
Each piece of new information helps us to either rule out certain possibilities on our list or make others more likely.
It's a process of elimination and refinement. We start broad with several potential diagnoses and gradually narrow it down to the most probable one.
And it's not just about finding a diagnosis, but also about considering if there might be more than one thing going on.
Exactly. Sometimes a patient might have co-occurring conditions. The differential diagnosis helps us to think comprehensively.
So it's a careful and ongoing process of considering all the potential explanations for a patient's presentation until the most accurate diagnosis or diagnoses can be determined.
It's a cornerstone of clinical reasoning in all fields of medicine, including psychiatry. Now going back to schizophrenia.
Right, and sometimes those auditory hallucinations.
Oh, go for it.
Wait, I'm not done with it yet. So the best, definition is to think about it. It's like a mental list that a physician or whoever, mental list of all the possible.
Exactly, that's a perfect way to think about it.
It's a dynamic mental checklist that helps guide the diagnostic process.
So with that in mind, when we're looking at schizophrenia,
We start considering those hallmark symptoms.
like oh yeah, let's hear it.
Wait, I'm not done with my question. I'm trying to say, I want to think of it as like a mental list of all the possible causes for the patient's symptoms. And then once, I have all those possible causes, I start kind of like narrowing it down and ruling out through like evidence and reasoning. It's like trying to solve a puzzle, right? Can you give me like a clinical example? For example, yeah, how would you do it, like step by step, in a clinical thinking? You know what I mean?
You've absolutely nailed the concept. It really is like a mental puzzle we're trying to solve.
And your idea of a mental list that we narrow down using evidence is spot on. Let's walk through a simplified clinical example.
Imagine a young adult comes in reporting feeling very down for several weeks. They say they've lost interest in their hobbies, are sleeping more than usual, and their appetite has changed.
So our initial differential diagnosis list might include major depressive disorder, like we discussed earlier.
But we also need to consider other possibilities, right?
Exactly. We think about adjustment disorder if there's been a recent stressful life event.
Or maybe even a medical condition like hypothyroidism, which can present with similar symptoms.
And we'd also want to ask about any substance use, as that can affect mood.
So that's our initial broad list of possibilities. Now, how do we narrow it down?
We start gathering more specific information. We'd ask detailed questions about mood. How low is it? Is it persistent? Have they experienced any periods of elevated mood?
We'd also delve into the medical history, any past mental health issues, and if there's any family history of depression or other conditions.
We might order blood tests to rule out medical causes, like a thyroid problems, and we'd carefully assess for any signs of substance use.
Let's say the blood tests come back normal. There's no recent stressful event and no indication of substance use. And the patient reports a persistent low mood with no history of elevated mood.
Based on that evidence, we can start to rule out some of those initial possibilities, making major depressive disorder the most likely diagnosis on our differential.
It's a step-by-step process of considering, gathering information, and then using that information to refine our understanding and arrive at the most accurate diagnosis.
Just like solving a puzzle. Now, as we were saying about schizophrenia.
Right. Other negative symptoms are things that are diminished. Yep. Go on.
Again, first, number one is why did you say hypothyroidism can cause that? Can you explain the reasoning behind it? Why it would cause it, like, your mood, like the person to feel depressed? And the second one is just do doctors have a checklist or a system, for example, on Epic, that software, to rule out all of these, kind of like clues, etc., to work on that differential diagnosis? How does that work? Do they have a book? Do they have or is it just mental? All of this happens in their head.
Those are great follow-up questions. Let's tackle the hypothyroidism link first.
Okay, let's unpack this. Your thyroid gland produces hormones that regulate a lot of bodily functions.
Here's where it gets really interesting. These hormones have a significant impact on brain function, including mood regulation.
What's fascinating here is that an underactive thyroid, or hypothyroidism, can slow down these brain processes.
What does this all mean? This slowing down can often manifest as symptoms like fatigue, low energy, and yes, even depression.
So it's not a primary psychiatric disorder, but a medical condition that can have a profound effect on mood.
Absolutely. That's why checking thyroid function is often part of the initial workup when someone presents with depressive symptoms.
Now, regarding your question about checklists or systems for differential diagnosis,
That's a very practical question, and the answer is it's a bit of both.
why there isn't always a ripped checklist in the way you might imagine.
But electronic health record systems like Epic often have built-in features.
These systems can help clinicians organize information and consider different diagnostic possibilities.
For example, entering certain symptoms might trigger a list of potential diagnoses.
And they can certainly help track lab results and other data relevant to ruling things out.
However, the core of differential diagnoses still relies heavily on clinical knowledge and experience.
It's about understanding which is likely given a particular presentation.
And it often involves consulting medical textbooks, guidelines, and colleagues.
So while technology assists, that clinical reasoning process you described is still absolutely essential.
Now, going back to those negative symptoms of schizophrenia,
Right. Other negative symptoms are things that are diminished or absent in a person's functioning.
and often social withdrawal becomes noticeable.
Now, just to clarify, how does schizoaffective disorder fit in?
Oh, yeah. Go on.
First of all, tell me a detailed definition of what schizophrenia is, as well as its etymology, and the same. What is the do the same for schizoaffective disorder?
Absolutely, let's dive into the definition.
Okay, let's unpack this. Schizophrenia is a severe and chronic mental disorder.
Its etymology comes from Greek words meaning split mind.
However, it's crucial to understand this doesn't mean split personality.
Instead, it refers to a split between thought, emotion, and behavior.
What's fascinating here is that it affects a person's ability to think clearly.
They may experience distorted perceptions of reality,
Positive symptoms are things added to normal experience.
like delusions, firmly held false belief, and hallucinations.
Hallucinations can involve any of the senses.
Auditory hallucinations, hearing voices, are quite common.
Negative symptoms involve a decrease or lack of normal functioning.
This includes things like flattened affect, reduced emotional expression,
Also, anhedonia, the inability to experience pleasure.
and abolition, a lack of motivation or drive.
Social withdrawal is another significant negative symptom.
Now, schizoaffective disorder involves symptoms of both schizophrenia.
And a major mood episode, either depression or mania,
So the person experiences psychotic symptoms.
along with significant mood disturbances.
The key distinction is the timing and duration of these symptoms,
There are periods where psychotic symptoms occur.
and also periods where both psychotic and mood symptoms are present.
This overlap makes it a distinct diagnosis from schizophrenia.
Oh, back to our listener. What's up?
Can you re-explain again what schizophrenia is and use a real-life example? Okay, make it as detailed as possible and as simple as possible.
Absolutely, we can definitely break that down for you again with a real-life example.
It's a really important condition to understand.
So think of schizophrenia as a chronic brain disorder that affects how a person thinks, feels, and behaves.
The term split mind in its origin refers to a disconnect in these areas, not a split personality.
Imagine someone named Alex. Alex might start hearing voices when no one else is around.
These aren't just their own thoughts, they sound like distinct people talking to them.
That's an example of an auditory hallucination, a positive symptom because it's an added experience.
Alex might also develop strong beliefs that aren't based in reality, even when presented with evidence to the contrary.
For instance, they might believe that the government is monitoring their thoughts through their television. That's a delusion.
Now, on the other side, Alex might also show negative symptoms, things that are taken away.
They might have a very flat affect, meaning their face doesn't show much emotion, even when talking about something sad or happy.
Alex might also lose interest in activities they used to enjoy, like hobbies or spending time with friends. That's anhedonia.
They might also struggle with motivation, finding it hard to start or finish tasks. Even simple ones, that's avolition.
So you have these added experiences like hallucinations and delusions, alongside a reduction in normal emotional expression and motivation.
These symptoms can make it very difficult for someone like Alex to maintain relationships, hold a job, or take care of themselves.
It's a complex interplay of these different types of symptoms that define schizophrenia.
It's not just one thing, and it affects each person differently, but these core elements are usually present.
Exactly. Now, the primary way we manage schizophrenia is often... Oh yeah, let's hear it.
So basically, schizophrenia, the etymology means split personality, and that is because there is a split or discrepancy between what's really happening and what the person is kind of like seeing, feeling, or, reporting. For example, if we have positive symptoms, right? The person is a little bit, we're adding things to reality. The person is adding things that don't exist to reality. Like they might, believe they're the president. They might see a monkey inside their bathroom. Or it could be negative, where, for example, they're losing things. They're losing, like they could be talking about a death and laughing at the same time. They're like losing that connection. That's, I don't know how to explain it, right? Also, what does RTIS mean? Responding to internal stimuli. What does it mean? Can you give me an example?
That's a really interesting way you're putting it.
You're hitting on some key aspects of schizophrenia.
But the idea of split personality, which is more accurately called dissociative identity disorder, is different.
With schizophrenia, it's not about having multiple distinct personalities.
Instead, as you pointed out, there's a disconnect between their perception of reality and what's actually happening.
Your examples of positive symptoms are right on.
Believing they're the president or seeing something that isn't there Those are examples of delusions and hallucinations.
And you've also grasped the essence of negative symptoms.
That reduction in emotional expression or that disconnect in their response, like laughing at a sad event.
It's like their inner experience doesn't quite align with the external situation.
As for RTIS, you're right, it stands for responding to internal stimuli.
Okay, let's unpack this. It refers to those subtle signs we might observe.
Here's where it gets really interesting. When someone is experiencing hallucinations, particularly auditory ones,
What's fascinating here is they might be reacting to those internal voices or sensations.
what does this all mean? You might see them looking to the side as if listening,
Or maybe they'll be whispering to themselves.
even smiling or appearing distracted for no apparent external reason.
So RTIS is an outward sign that they are likely experiencing those internal stimuli.
Now, the primary way we manage schizophrenia involves antipsychotic medication. Yeah.
For example, AVH as well as RTIS, are they only a sign, of positive symptoms seen in schizophrenia? Meaning, can they be like, can someone with bipolar disorder have them? Can someone with depression have them? Can someone with, I don't
That's
know.
a really insightful question about AVH and RTIS.
You're asking if these are exclusively seen in schizophrenia.
Well, AVH, or auditory verbal hallucinations, and RTIS, responding to internal stimuli, are certainly hallmark positive symptoms of schizophrenia.
But it's important to understand that they can sometimes occur in other conditions as well.
For example, someone experiencing a manic episode in bipolar disorder might have psychotic features.
And those features could include hallucinations, though often less persistent than in schizophrenia.
And you're right, even in severe cases of depression, sometimes with psychotic features, hallucinations can occur.
So while these signs are very suggestive of schizophrenia, their presence alone isn't always enough for a definitive diagnosis.
It's the constellation of symptom and the overall clinical picture that helps differentiate patients.
Now, we were just about to talk about antipsychotic medications used to manage schizophrenia.
And the potential for tardive dyskinesia with...
All right, so according to what you're saying, things are not kind of like black or white. We may have a person, with a bipolar.
That's a really astute observation. You're absolutely right.
Psychiatric.
Oh, go for it.
Wait, I'm not done. I said that not everything is black and white, right? So we might see, according to what you said, a person with bipolar disorder that presents with symptoms, for example, positive symptoms of schizophrenia, like talking to themselves or having visual hallucinations, etc., or responding to internal stimuli. Can that be possible? Or can this be applied to major depressive disorder, etc., etc.?
Exactly. You're picking up on a really key point about psychiatric conditions.
Things aren't always neatly separated into distinct boxes.
So yes, it is possible for someone with bipolar disorder, particularly during a manic episode.
To experience psychotic symptoms that we often associate with schizophrenia.
Things like visual or auditory hallucinations or disorganized thoughts that might lead to talking to themselves.
And you're also right that in severe cases of major depressive disorder,
Especially if it's classified as depression with psychotic features.
a person might also experience hallucinations or delusions.
So what does this all mean? It highlights the complexity of psychiatric assessment.
It's about looking at the whole picture, not just individual signs.
And that applies to how medications work too, right?
Exactly. As we've seen, some medications can be helpful for more than one condition.
Like certain atypical antipsychotics used for both schizophrenia and bipolar disorder.
And even within a diagnostic category, people can respond differently to the same medication.
So it's not always a clear-cut case of this drug for that disorder.
It often involves careful observation and tailored treatment to the individual.
Now, we were about to mention that, fortunately, if those EPS side effects from older antipsychotics do occur,
Medications like Benadryl can often help manage them.
when we look at the atypical antipsychotics again,
Medications like Abilify, Risperdal, and Zyprexa,
these generally have a lower likelihood of causing those EPS issues we talked about earlier.
which can significantly improve a patient's experience with the medication.
However, we do need to be mindful of metabolic... Oh, yeah,
All right. Okay, we said, first of all, that, antipsychotics are not necessarily only used for, for schizophrenia or schizoaffective disorder. They can also be used in, bipolar disorders, or I don't know. Are there any other things where they are used? And then again, can you tell me what the difference is between typical antipsychotics and atypical antipsychotics? Why are they called like that? And give me examples and yeah, what we use them for.
You're right to bring up the versatility of antipsychotics.
It's a really good point that they're not solely for schizophrenia,
As we've touched on, atypical antipsychotics are often used in bipolar disorder.
particularly during manic episodes or for mood stabilization,
They can also be used in severe cases of depression,
especially when there are psychotic features present.
and sometimes in other conditions with significant agitation or aggression.
Now, about the difference between typical and atypical antipsychotics.
The terms refer to when they were developed primarily.
The typicals, or first generation, came out earlier.
Think of medications like haloperidol and chlorpromazine as examples.
Their main action is strongly blocking dopamine receptors in the brain.
This is effective in reducing the positive symptoms of schizophrenia.
But as we discussed, this strong dopamine blockade also leads to a higher risk of EPS.
Those extrapyramidal symptoms affecting movement.
The atypicals, or second generation, came later.
Examples include Seroquel, Risperdal, and Zyprexa.
While they also affect dopamine, they have a greater influence on other neurotransmitters.
Especially serotonin, which is thought to contribute to their different side effect profile.
They generally have a lower risk of EPS compared to the typicals.
However, they often carry a higher risk of metabolic side effects.
Things like weight gain, increased blood sugar, and changes in cholesterol.
So the distinction really comes down to their primary targets and side effect profiles.
It influences which medication might be chosen based on a person's specific needs and risks.
Now, as we were saying, we need to be mindful of... Oh, yeah.
All right, first of all, explain, Benadryl and, say its generic name and its commercial name. The same with Cogentin. Say what classification or class of meds they
It's
are.
a really helpful request to clarify those medications.
Yeah.
Hey, yeah, what's up?
Explain what Benadryl is. Include its, like generic name as well as its commercial name or whatever. Do the same with Cogentin. Say what class of medications they are. How do they work with the EPS? Why are they used on EPS? The same for Abilify, and what is it when it's used? And you said monitor for metabolic syndrome, like with atypical antipsychotics. Why? What do they do exactly? Can you tell me the pathophysiology, etiology behind it?
Okay, let's unpack each of those. Benadryl's commercial name is diphenhydramine.
And diphenhydramine is an antihistamine medication.
Cogentin's commercial name is benstropine.
Benstropine belongs to a class of drugs called anticholinergics.
When we talk about EPS, it's often due to an imbalance of dopamine and acetylcholine in the brain.
Here's where it gets really interesting. Antipsychotics lower dopamine levels.
So anticholinergics like benstropine help by blocking acetylcholine.
What's fascinating here is that this helps to restore some balance and reduce EPS symptoms.
Benadryl, while primarily an antihistamine, also has anticholinergic properties.
What does this all mean? It can also help with some EPS, especially acute dystonic reactions.
Now, Abilify's generic name is aripiprazole. It's an atypical antipsychotic.
Atypical antipsychotics are used for schizophrenia and bipolar disorder, among other things.
They work by affecting both dopamine and serotonin levels in the brain.
And as we discussed, they generally have a lower risk of EPS compared to the older antipsychotics.
Finally, regarding metabolic syndrome, mono was my shorthand. Apologies.
What does this all mean? Metabolic syndrome with atypical antipsychotics is complex.
What's fascinating here is that these medications can affect appetite regulation.
Here's where it gets really interesting. They can lead to increased appetite and weight gain.
They can also impact how the body processes glucose and lipids.
This can result in hyperglycemia, dyslipidemia, and increased risk of type 2 diabetes.
The exact pathophysiology is still being researched, but involves complex interactions.
It involves neurotransmitter pathways and their effects on metabolic processes.
So medications like Benadryl and Cogentin help manage the side effects of some antipsychotics.
While Abilify is an antipsychotic itself, with a different side effect profile,
And metabolic syndrome is a potential consequence of some atypical antipsychotics.
it's important to monitor for all of these things in patient care.
And it can help reduce EPS symptoms, particularly acute dystonic reactions.
Cogentin, or benstropine,
Go for it.
All right, number one, what is it called? Okay, separately, like what happens in schizophrenia? What neurotransmitters are all messed up? What's the problem in schizophrenia? First of all, let's do that first.
That's a really important question to address directly.
Okay, let's unpack this. In schizophrenia, several neurotransmitter systems are thought to be dysregulated.
But the most prominent theory involves dopamine.
Here's where it gets really interesting, suggesting an overactivity of dopamine in certain brain areas.
What's fascinating here is that this excess dopamine activity is strongly linked to the positive symptoms.
So things like hallucinations and delusions might be related to too much dopamine signaling,
However, it's not just about dopamine. Other neurotransmitters are also implicated.
such as serotonin. Remember, we talked about its role in mood.
Well, serotonin is also thought to interact with the dopamine system in complex ways in schizophrenia.
And glutamate, which is a major excitatory neurotransmitter in the brain.
There's research suggesting that problems with glutamate signaling might contribute to some of the cognitive symptoms.
So what does this all mean? It's a complex interplay of several neurotransmitters.
While dopamine overactivity is a key feature, other systems like serotonin and glutamate are also involved in the complexities of schizophrenia.
It's not just one cell being messed up, but rather a network of imbalances.
And this understanding guides how antipsychotic medications work, often targeting these neurotransmitter systems.
Now, we were about to talk about how feeling those side effects can be really distressing.
And this is so important because feeling those side effects can be really distressing.
Exactly, and it can impact their willingness to continue their medication.
Now, shifting gears slightly, we were discussing the importance of sleep.
Yes, and this isn't just about feeling tired, it can really exacerbate symptoms. Oh yeah, let's hear it.
All right. Okay. We said that, just to recap as an overview, all right? So basically, antipsychotics are not necessarily used for schizophrenia. They can be used sometime, rarely, I guess, for major depressive disorders. They can be used for some sort of bipolar disorders. They can be used for schizophrenia or schizoaffective disorder, right? Okay, so what do antipsychotics target, first of all? Like what neurotransmitters?
You've got a good overview there. You're right. Antipsychotics have a range of uses.
So when we talk about what they target, the primary focus is often on dopamine.
As we discussed with schizophrenia, many antipsychotics work by blocking dopamine receptors in the brain.
That's how they can help reduce those positive symptoms like hallucinations and delusions.
However, especially with the atypical or second-generation antipsychotics, it's not just dopamine.
Right, many of them also have a significant effect on serotonin receptors as well.
This dual action on dopamine and serotonin is thought to contribute to their broader range of uses.
And as we've touched on, this also influences their side effect profiles.
Now, bring us back to our discussion on sleep.
Yes. And as we were saying, this isn't just about feeling tired. It can... Yep. Go on.
All right. And then for typical antipsychotics, also known as first generation antipsychotics, when EPS,
You're asking when...
Oh, yeah. Go on.
wait, I'm not done. With typical antipsychotics, right? Also known as first generation antipsychotics. When EPS side effects occur, why do we give Benadryl and Cogentin? What class of medications are they, and what is the logic behind using them in these situations?
That's a really important question to clarify.
You want to know why we use Benadryl and Cogentin for EPS?
Benadryl, or diphenhydramine, is an antihistamine.
And Cogentin, or benztropine, is an anticholinergic.
When those older antipsychotics block dopamine.
It can create an imbalance with another neurotransmitter called acetylcholine.
So anticholinergics like Cogentin help to restore that balance.
Benadryl also has anticholinergic properties,
So it can also help reduce some EPS symptoms.
especially those early acute reactions.
You're also wondering when EPS might occur.
It can actually happen relatively soon after starting these medications.
Those different types of EPS can appear at different times.
Acute dystonia, those sudden muscle contractions, can be quite early.
And Parkinsonism, with tremors and stiffness, might develop within weeks.
Akathisia, that inner restlessness, can also show up fairly early.
So it's important to watch for these signs from the start.
However, tardive dyskinesia tends to be a later side effect. Oh, back to our listener. What's up?
All right, so you're saying that typical antipsychotics tend, to mess by trying to regulate that dopamine. They also have a side effect, which is messing with acetylcholine, right? And that Benadryl and Cogentin help regulate the relationship or that connection between dopamine and acetylcholine, right? Can you tell me how they do that? And also, what is acetylcholine? Like, what is its function? Can you describe it? What is it? Is it a neurotransmitter, a hormone? What is it?
You've got a really good grasp of the connection there.
You're right. It's about reestablishing a better balance.
Okay, let's unpack this. When dopamine is blocked, the relative level of acetylcholine can become higher.
Here's where it gets really interesting. Acetylcholine has many functions, including playing a role in muscle movement.
What's fascinating here is that the overactivity of acetylcholine, due to the dopamine blockade, is thought to contribute to those EPS symptoms.
What does this all mean? Anticholinergics like bestropine work by blocking acetylcholine.
This helps to bring the levels of dopamine and acetylcholine back into a more harmonious relationship.
Benadryl, as an antihistamine with anticholinergic effects, does a similar thing, though often less directly than bestropine.
Now, about acetylcholine itself, yes, it is a neurotransmitter.
Exactly. It's a chemical messenger that transmits signals between nerve cells,
It's involved in a wide range of bodily functions.
including muscle contraction, memory, learning, and even sleep regulation.
So, by using anticholinergics, we're essentially dampening down the effects of acetylcholine to counter the dopamine blockade.
Recognizing these early EPS signs and acting quickly is key.
Using Benadryl or Cogentin can really improve how someone feels.
And thinking about sleep, using those PRN aids thoughtfully can help.
Medications like trazodone can promote rest without heavy sedation.
Finally, just to briefly mention the value of good communication.
It's so important for building trust with our patients.
And always remembering to watch for those early EPS signs.
Recognizing them and acting promptly really matters.
We've covered a lot of crucial information today.
Yes, understanding these basics is so essential.
We really appreciate all of your insightful questions.
Thank you for being such an engaged listener today.
We hope this has been helpful. Oh yeah, let's hear it.
Before we finish, can you give me a recap of the most important stuff?
Absolutely. We can definitely do a quick rundown of some key takeaways.
It's a great way to solidify what we've discussed before we wrap up.
Okay, let's unpack this. We started by talking about depression.
And the role of SSRIs in increasing serotonin levels in the brain.
We highlighted that these medications take time, usually 2 to 4 weeks.
And we also discussed some common side effects to be aware of.
Then we moved on to bipolar disorder.
And the importance of mood stabilizers like lithium.
We emphasized lithium's narrow therapeutic index.
And the need for careful monitoring for toxicity.
We also touched on other mood stabilizers like Seroquel
Noting its potential for QTC prolongation.
and Depakote, highlighting the need to monitor liver function,
Next, we delve into schizophrenia.
exploring the positive and negative symptoms.
And the difference between typical and atypical antipsychotics.
We talked about the higher risk of EPS with typical.
And the increased risk of metabolic syndrome with atypicals.
We also discussed how Benadryl and Cogentin can help with EPS.
And the importance of recognizing RTIS as a subtle sign.
We also underscored that these conditions can sometimes overlap in symptoms.
And that careful assessment is always crucial.
Finally, we touched on the vital role of sleep.
And how crucial it is in managing psychiatric conditions.
Does that quick overview hit the main points for you?
We're happy to elaborate on any of those further if you like.
But otherwise, thank you again for joining us today.
It's always a pleasure having you listen and contribute.
We hope you found this discussion insightful.
And I look forward to our next conversation.